Great. All right, welcome again, everybody. We had such great talks for the APP session, and we are really thankful to all of you. We just want to do a quick Q&A session. We did have a question from the audience in regards to testing. So if Dr. Velez, actually everybody here, even Andrea Thurler, Dr. Velez, Dr. Bonneman, if you want to help answer this question. One audience member was wondering if one should always order a confirmatory test to confirm achalasia, even if ESMO is very diagnostic for achalasia.
I think that question, the answer just depends on the clinical suspicion for achalasia, if there is a result that's unexpected. I think in the setting where there is high suspicion and the ESMO, the esophageal manometry is a bit ambiguous, and it may be that you need to look at other adjunctive testing. But in this case where, for example, you're doing a manometry as a part of a placement for a catheter-based ambulatory reflux probe, maybe not as much. So it depends on the scenario.
Interesting, very interesting. Dr. Bonneman, do you have thoughts on this, or Andrea? Do you have thoughts?
One comment is always do a barium swallow in those patients. You'll know how long their disease has been there. The wider the esophagus, the longer it's been there, which affects their response to therapy. And it will keep you out of trouble all kinds of ways. So I'm a fan of at least a barium X-ray. In addition to that, I'm a fan of the time barium swallow. You also can use it to follow therapy afterwards. So do a confirmatory test.
Interesting. All right.
Andrea, I'm wondering, how can an APP or anybody interested in learning hypnotherapy, are there resources for that?
Yeah, thanks for asking, Alex. So there's the Society of Clinical Hypnosis. It's actually a 3-day course. So it's really not that long. And it's a course that I traveled actually with our psychologist, Dr. Lerner. We went down to Virginia, and they had a whole long weekend course training on this. So it's very open to, there's multiple tiers. So I did the first introductory tier, but then you can do, advanced and other things with it. So I thought the introductory was very helpful, just to get a basic understanding and then build from there. And there's a great group that I work with Helen that talks a little bit about, hypnosis and things like that. That's been good.
Oh, it's very exciting. We also have another question, Alex and I, in regards to manometry. We know Dr. Neff talked about manometry, but Dr. Bonneman, Dr. Velez, if you can answer this too. But as APPs, we always get a reading of the manometry, and really in regards to how to read it or what to do is sort of sometimes confusing, and we have to touch base with our attendings. But is there any training mechanisms to learn manometry for an APP, or how to interpret it, at least from the APP perspective?
I think, great question. I think that I would make it a 30,000-foot view. On top of that, most gastroenterologists aren't well-versed in attending, physicians aren't well-versed in manometry either. It's a skill set that it doesn't take a lot to become familiar with the overarching principles like integrated relaxation, pressure, LE, lower esophageal sphincter, esophageal body, but to really feel comfortable to resolve those same dilemmas that you're mentioning, it really takes a lot. So there isn't really, and I think part of it is just because that the mechanisms to make that training they're hard to standardize. And I'm not sure, Dr. Bonneman, if you have any other input.
Yeah, the one suggestion, if you order enough of these, that would be good to do is, and actually we have to thank really Dr. Pandolfino for that, is that the iteration of each of the Chicago versions of how these things get interpreted, we're now up to Chicago 4, have these very helpful reviews with pictures and examples. And these are not too difficult to find through PubMed. Usually they're published in Neurogastroenterology, our journal, but they're usually quite readable and include pictures enough so you get an idea of what sort of, these things are about and what they do. So that would be a good starting place. And as Chris said, just ask. Any of us are happy to help you with this. And the more of these you order, the more you kind of look at the easier it's going to get. But yeah, exactly like you said, Chris.
Very nice. Great, thank you. I think maybe one quick minute question for Sarah. How do you explain dietary restrictions to patients with achalasia?
Yeah, that's a great question. So Really, I think, I mean, most of these patients are surgical patients, right? So it's important to kind of explain for symptom relief or at least some management before surgery. And then also after surgery, there's a period of time where you need to follow dietary modifications. So usually I talk about it in terms of it kind of is a tool in the toolbox along with other interventions. And in terms of how I explain the specifics of the diet, that's really done in usually a 20 to 30 minute visit. So really it's kind of taking the time to understand the patient's diet in the first place and how to modify it. So you're not just kind of handing them a sheet with, you know, the level 1, level 2 dysphagia diet and saying, good luck, right? So it's really kind of making sure that they understand what their specific diet is going to look like.
Great. All right, I think we are out of time. So we will be back in 1 second. Thank you, everyone.
Yes, thank you very much.